Hello, everyone, and welcome to our presentation entitled Cherokee Health System's Hypertension Monitoring Remote Program. This project was completed by myself, Heidi Honeycutt, Scott Trauma, and Phoebe Waller. This is a quick overview of what we will be discussing today. We will start with a brief background on hypertension statistics in Tennessee and learning more about the healthcare facility, Cherokee Health Systems, in which we partnered with during this project. We will discuss our goals and objectives, intervention plan, survey results, and then we'll finish up with a discussion and conclusion. So starting off with a few facts regarding hypertension. Hypertension is exceptionally high among Tennessee. More specifically, it's 6% higher than the national average with a prevalence of 39%. Untreated hypertension can result in negative outcomes, including heart disease, which is the leading cause of death nationally. Heart disease is associated with roughly 500,000 deaths per year. Along with this, an elevated blood pressure is linked to several comorbidities. Some of these include a greater chance of developing type 2 diabetes, cardiovascular disease, and kidney failure. Untreated hypertension can also play a psychological and social role. Several studies have indicated that hypertension results in greater stress and overall poor quality of life. This overview of hypertension really illuminates the importance of providing more patient education and resources to these patients. In fact, research has indicated that educating clients regarding hypertension and proper blood pressure monitoring results in greater health outcomes. And this leads to the impact Cherokee Health Systems is making through this newly initiated hypertension monitoring program. So here's a little background on CHS. It is a non-for-profit primary care facility. It reaches roughly over 70,000 patients in the state of Tennessee. And the majority of those that are reached are underserved and underinsured individuals. CHS facilities are considered a federally qualified health center, and this means that they can provide services and resources to patients to underserved communities based on a sliding scale payment. Along with primary care, CHS has several specialty clinics, including women's health, dentistry, pharmacy, and behavioral health. And these statistics really showcase how needed these facilities like CHS are in this Knoxville community. So 94% of CHS patients fall at or below 200% of the poverty line, and close to 20% of patients are considered to have no health insurance coverage. An aspect that really brings attention to our specific program is that hypertension is the most common chronic disease seen at CHS. So this signifies the importance of targeting the specific patient population. So there's an immense need for educating and ensuring that these patients at CHS feel confident in both measuring and managing their blood pressure. Like we've mentioned before, there is a high rate of hypertension, especially in Tennessee and these CHS populations. So in fact, back in 2020, there was a 5% increase in diagnosing hypertension at CHS locations. Research has really indicated that educating clients regarding hypertension and blood pressure monitoring results in positive health outcomes combined with pharmaceutical interventions. And this can just lead to a greater result in achieving a healthy blood pressure range. So overall, there's an overwhelming need for clear and concise education materials for this specific patient population. Here is our stated goal for the project. So CHS patients with hypertension will increase their self-efficacy by utilizing heart-healthy nutrition education and an at-home blood pressure monitoring kit. These are our objectives. The process objective states the implementation team will develop educational materials regarding hypertension and nutrition education to supplement the existing CHS blood pressure monitoring program. The impact objective states that the team will develop and distribute 2 surveys based on patient education and materials to evaluate the effectiveness. The outcome objective is based on these results that from the surveys that the CHS pharmacy will implement these resources regularly and to more patients to increase self-efficacy and knowledge to patients. The intervention plan for this project started out with working closely with CHS Pharmacy and Knox County Health Department to develop and collect existing education and resources for this specific program. We met with CHS Pharmacy twice over the course of the semester and gained valuable insight into the scope of the project, and we received valuable feedback as well as collaboration on the content and layout for these patient packets. Then the second phase involved Knox County Health Department printing off the materials and then the pharmacy team assembling the packets. Mainly our focus was on ensuring that the patients understand how to properly measure their blood pressure with the kit, as well as providing nutrition education solely on dietary approaches to stop hypertension and sodium reduction. These resources were introduced during the initial visit with CHS Pharmacy and the patient. And our end goal of this initial visit was not only to provide the education, but also have the patients fill out a quick half-page survey on the effectiveness of the education. So now we will cover what type of education was provided in these packets. And this picture is just a broad picture of everything that was included for the patient packets. This first handout was created by the American Heart Association, and this lists various blood pressure categories, as well as correlating them to the values of the blood pressure readings. We thought that this was vital to provide as a way for patients to fully understand where they fall under these categories while they're checking their blood pressure. This next handout is a great visual for patients to see how to properly measure their blood pressure. So it shows a man sitting with his legs uncrossed in a relaxed position. This can serve as a helpful guide when patients are starting out using their kit and their new device. And this pocket-sized booklet we also included in the packets as a way for patients to be able to hand document their blood pressure readings. So the chart offers a date and time range, which can be extremely helpful in identifying different patterns of highs and lows, and also valuable information for healthcare providers.
Now we are going to look at the two materials in this packet that focus on nutrition facts, food examples, and tips and tricks to eating a more heart-healthy diet. Our goal with these last two documents was to outline the components of the evidence-based diet called the DASH diet, or the dietary approaches to stop hypertension. But we wanted to do this in a way that was easily understandable and does not give the idea that patients need to be on a restrictive diet, but encourages food choices and habits that are really sustainable for overall heart health. This first handout was created by the Knox County Public Health Department, and it outlines 6 foods that have the most sodium in the typical American diet, which are bread, deli meat, burritos, and tacos, pizza, soups, and sandwiches. It also gives a clear description of each item in the Salty 6 to clarify what falls under each category. The back of this document was created by us, the student team, to fit the needs of the Cherokee Health System patients using real-world examples given to us by the Cherokee staff about questions that they've commonly seen regarding salt specifically. This side gives tips for eating less sodium, information about the recommended daily limit for salt, and 2 fun facts that are also important to keep in mind when trying to eat a heart-healthy diet. The last handout was created by the Oregon Health Sciences University. We loved that this handout outlined the heart healthy plate with recommended portion sizes and also gave examples of foods that fall into these categories. It also gives information about water and calorie-free beverages, healthy fats, and low-fat dairy on the edges around the plate. And you can even use this handout as inspiration for meal times with accurate portion sizes for each component of the meal. So the back of this document has examples of healthy snacks and tips for having a heart healthy diet overall. It also includes information about physical activity in that red box, which we feel was important for the clients at Cherokee to have as well. Another pro of this document is that there's already a version available in Spanish, which can help diversify who can receive these supplemental materials in the future of this program. So this is the half sheet given to the patients in their packet to fill out about the 5 supplemental materials. Our goal was to find a validated source like the PMAT for those questions, but we couldn't find one specific enough for what we were trying to measure. So we wanted to make sure that the sentences that we used were very simple language and not too long, because we didn't want to take too much time away from the patients and pharmacists during this intake appointment where they're receiving these packets. The questions asked were, I understood the materials in the packet. I learned at least one action I can take for the better heart health. There were not too many words or pictures in the packet. I learned how my diet impacts my blood pressure, and I am confident that I can manage my overall blood pressure numbers. Overall, we had 25 respondents, which we are thrilled about, and the next 2 slides are going to outline these results. We had the first 4 questions placed on a scale similar to an official Likert scale, and what these did were categorize the agreements about how much the patient agreed with each of these sentences about our 5 materials in this packet. Overall, our results were very positive. We had no one choose disagree and only a handful of strongly disagrees. And the majority of patients chose agree or strongly agree to understanding and applying these materials. Our results continue to stay positive for the confidence questions as well. All respondents selected a 3 or higher, indicating a strong confidence in managing blood pressure numbers using the at-home blood pressure monitor. We did want to note that this confidence is likely coming from the amazing preparation and education being provided from the Cherokee staff themselves, and that our material is likely just supplementing the amazing work that they're doing. And we want that these materials to continue to increase confidence that the patients already have. But it is very likely that just the prep that they've been getting face to face with Cherokee has started this confidence. And the goal for these materials is for that confidence to continue.
Okay, so I'm going to discuss the evaluation tool that we used with providers and with educators to evaluate the materials that were included in these packets. And this actually is a validated tool called the PMAT, which stands for Patient Education Materials Assessment Tool. So this survey was distributed to CHS pharmacists, Knox County Health Department professionals, and UTK nutrition professionals, also along with some other nutrition professionals within the community. And the main objective of this evaluation tool is to evaluate both the understandability and the actionability of these materials for Cherokee patients. So are they easy enough and simple enough to be understood by that population? And does that population feel like they can take the information that they learned from those materials and turn them into actions that they can take within their daily lives? So we use the PMAT for printed materials. There are different versions for printed materials or audiovisual materials. And this survey consists of 24 different items. The responses are very simple. It's either a 1 for an agreement or a 0 for disagree. They also have the option of choosing not applicable, just based on the specific materials that they received and the questions. Within those 24 items, it's broken down into a separate section for understandability and for actionability. The understandability section contains 17 questions, while the actionability one contains 7. And these are just a couple different screenshots that show an example of what some of the questions in the survey are like. So on the left side of the screen, those questions are evaluating the understandability of the materials. And the 3 examples that we have displayed here are: the material makes its purpose completely evident. The material does not include information or content that distracts from its purpose. And the material uses common everyday language. On the right side, we have a few questions that are evaluating the actionability of the materials. And those examples are: the material clearly identifies at least one action that the user can take. The material addresses the user directly when describing actions. And the material breaks down any action into manageable, explicit steps. And this is just a brief overview of who we had responding to this survey. So as you can see, we had 8 respondents classify themselves as healthcare workers, 4 classify themselves as dietitians. We had 2 social workers, a student, an educator, and 1 other. And this right here is a quick breakdown of our overall results when it comes to the understandability of the materials. And what we found was that respondents overwhelmingly answered that they agreed that the materials were understandable. The way that we compiled these results was to take all of the answers within that understandability section, add them together, and then divide them by 100. So we had 94% of the overall responses suggest that the materials were understandable according to these providers. The question that scored the lowest in this section was: the material offers a summary, which 76 of the respondents suggested that it does offer a summary. So just one thing that we can keep in mind when we evaluate potential changes for these materials going forward, as that was the biggest opportunity for change suggested by these responses. And this just breaks down our responses regarding the actionability of the materials. So as you can see, 91.5% of responses were overall favorable regarding the actionability, suggesting that our providers did find these materials actionable. Once again, these were compiled by just adding all of the different question responses and then averaging them. And the question that showed the greatest room for improvement was: the material offers a tangible tool whenever it could help the user take action. And I'm just going to quickly discuss some of the strengths and limitations of our project here. One of our overall strengths was that there was a very low cost for the project. We did not have a ton of expensive materials necessary. We had just fairly brief time spent by the implementation team. Most of our materials were simple papers. So it's not a project that's going to take a lot of expenses to get going. We collaborated with a lot of different disciplines. We had educators, students, we had pharmacists from Cherokee Health Systems, nurses from Cherokee Health Systems, educators. We had different professionals within the community evaluating our survey materials. So we had a lot of different perspectives to give us feedback on this project. And we received valuable feedback both from the patients and from professionals within the community. So this gives us multiple perspectives on the material. And we know that patients and healthcare professionals may just see these materials differently. So we found it really valuable to get feedback on 2 different ends. Limitations of this project are that initially we were only able to offer these materials to English-speaking patients. And that's something that, especially considering Cherokee Health System's large population of Spanish-speaking patients, we're definitely looking forward to being able to offer these materials to a wider variety of different, in a wide variety of different languages going forward. And then another limitation is that we did only have a small sample size for our evaluation tools. And this is to be expected when you first implement a project. And we were on a little bit of a time crunch, but going forward, we would definitely want to have a larger sample of respondents before we decide on any changes to make to the materials. And now just some quick discussion points regarding the project. So as we could see in the breakdown of the results, the feedback regarding these materials was very positive overall. And then some directions that we could try to take this program in the future for evaluation. We would love to conduct some focus groups, especially with patients, get a little bit more of a qualitative perspective on their experience in the project. So we think that could be valuable to conduct some small focus groups. Evaluation of blood pressure changes over time within the participants. We'd love to see the success of this program showing up in the numbers. And then just a larger sample of evaluations, both from the participants and the clinicians, like we said, would help to give us a little bit more confidence in those evaluations before we decide on any changes to make to these materials. So in conclusion, the CHS Hypertension Monitoring Remote Program gives us a really good chance to address what is most definitely a significant health issue within the community. And we discussed at the beginning that not only is this a significant health issue within the United States, but it's even more significant within Tennessee and within Knox County, and even more significant within the Cherokee health systems population. So this gives us a chance to target an intervention at a population that really could stand to benefit from it. Especially considering the target population, we found it really, really important that these materials that we distributed to them were both understandable and actionable. And then once again, our early survey results, while based on relatively small samples, suggested positive feedback. And they give us a lot of optimism regarding the future of this program and how it may be able to help these patients going forward. And this is just a screen cap of our logic model. So here you've got some inputs, some outputs or outcomes on the overall impact on the patient population, and then some assumptions and external factors at the bottom that also could have an impact on the project. And lastly, a thank you to our key contributors. First and foremost, we would love to thank Michaela McKeever, who has been kind of our advisor working with the Knox County Health Department throughout each of the last 2 semesters. We could not have possibly asked for a better preceptor. She has been so patient when it comes to working with us, giving us a perfect balance of autonomy and education and oversight. And we've learned a ton from her, and we really appreciate all the time that she spent on this. The same goes for Dr. Marcia Spence, who has just been a perfect faculty advisor on this project over the last 2 semesters. Once again, has given us perfect feedback, but has also given us enough autonomy to really feel like we were in control of this. Sarah Boswell, PharmD from Cherokee Health Systems, was extremely instrumental when it came to distributing these materials, evaluating them, giving us feedback on what will work and what wouldn't work with the Cherokee Health Systems population. And we really appreciate all the time she spent on this. Same goes for Karen Clausen, the Director of Pharmacy for Cherokee Health Systems. She also put a lot of time into this project, was extremely instrumental behind the scenes, making sure that everything was coordinated well, so that we were able to carry out the different steps of the intervention to schedule and get this thing running within the space of 1 semester. So a huge, huge thank you to everybody who helped to contribute along the way. And these are our references.